start, I'll introduce myself. I'm Jackie Crosati. I'm the chair of Crohn's and Colitis UK, and it's a huge welcome from me and from everyone at the charity and from IBD UK Alliance. Thank you so much for joining us. This is about the launch of the IBD UK National Report, the State of IBD Care in the UK. And it's a landmark report. It's a real milestone for us and our understanding of IBD care in the UK. It's proposing practical solutions to address the challenges faced by people living with Crohn's and colitis. And as you'll be aware, in the UK, it's around 1 in 123 people who suffer from the conditions, over 500,000 people. Very much a forgotten, invisible condition. And there are an awful lot of barriers to timely diagnosis, comprehensive care and support needed. So very important report for us. I'm delighted to welcome you to this launch, and I'm going to hand over now to Fern, who will take you through the rest of the evening. Thank you.
Thank you so much, Jackie. Welcome, everyone. I have the privilege of chairing today's session. I'm the Interim Director of Services, Advocacy and Evidence at Crohn's and Colitis UK, who provide the Secretariat for the IBD UK Alliance. Just a bit of housekeeping. So welcome to everyone. If you want to introduce yourselves on the chat, please do say who you are and who you're representing. You will notice that all attendees are on mute, but you will also notice that there is a Q&A function. There will be a Q&A session at the end, so please add any questions throughout the presentations to the Q&A function, and that will be monitored by staff members. There's also an opportunity to give a thumbs up and vote so we can see which are the questions that people want to answer. So today we're going to run through a very packed agenda. We'll be talking through the main findings and recommendations of the IBD UK report, have the perspective of lived experience, and introducing speakers from across the UK who will be highlighting examples of best practice and challenges in IBD care. And the session will close at around 7:15. So I will start by talking through IBD UK and setting the scene. So what does the national report tell us? Well, over 17,000 patients and 150 IBD services participated in the surveys, and the report is the largest of its kind, presenting a unique insight into the state of IBD care across the UK, which are benchmarked across the IBD standards. So we're here today to discuss not only the challenges, but also the opportunities to transform the way we deliver IBD care. And by working together, we can ensure that every person living with IBD receives the high quality and personalised care that they deserve. And I want to take a moment just to say that this report would not have been possible without the collaborative efforts of our partners. IBD UK represents 16 member organisations, and together we've combined clinical expertise, research insights, and the patient voice to create a report that is both comprehensive and also actionable. But our work does not stop here. And these partnerships remind us of the power of collaboration and how, as charities, clinicians, and policymakers and stakeholders across the UK, we must work together to look at the systemic issues in IBD care and look at how we can work together to create meaningful change for patients. So what are the IBD standards? The IBD standards are a framework of statements that define what should be put in place to deliver high quality care for people with IBD. They say what high quality care should look like at every point of the patient journey and how an IBD service needs to be organised. So the standards are intended to encourage IBD services to recognise what they are doing well and also to identify areas where they should improve. The latest version of the standards was launched in 2019, and that includes 59 recommendations along the patient care pathway. So since the standards were launched, the benchmarking took place. And whilst we acknowledge that progress has been made in raising awareness of Crohn's and colitis in those 5 years, the stark reality is that care for people living with IBD in the UK has not improved since 2019, that no IBD service currently meets the standards, which is a sobering statement, and it should make us pause and think that, simply put, too many patients are facing significant delays and barriers in all aspects of their care. So to provide an assessment of IBD care, patients were asked how they would rate the quality of their care. And it's a very sobering message that over a third of adults rated their care as fair or poor, which was more than the last time that the benchmarking took place in 2019. So I'm going to pause there, and I'm going to hand over to Dr. Barney Hawthorne, who's going to talk through the report in more detail.
Thank you very much, Fern. Yes, I'm going to talk about some of the findings of the report and some of the recommendations. Next slide. And as you've been told, this is a huge survey. We've got a wealth of data, but this data is intended to drive quality improvement. And the key here is local quality improvement in individual services. And we hope that that will be done in partnership with local patients as well. And of course, we've got the national report for a national overview, but the real work is going to be done at a local level. Next. So as we've heard, looking overall at the patient-reported quality of care for the services that they've been cared for by, we can see that 2 important things. Firstly, the pediatric patients report higher levels of satisfaction than adults, and this was exactly the same in 2019. And on the adult side, as we've heard, the overall level of satisfaction has actually gone down from 71% to 65% from 2023. If we look at the 4 UK nations, you see that the levels are slightly higher in Northern Ireland and Scotland compared to Wales and England, but in fact, this is not statistically significant. Next slide. I'm just going to talk about some specific areas in the report, and the first one is to talk about diagnosis, and particularly the issue of delayed diagnosis. We have over 2,000 patients who had been diagnosed within the 2 years before the survey, and they have reported the weights that they had before they were diagnosed, and it's been broken down into 4 segments. And this is shown schematically here with these coloured bars. If you look along the bottom, that is the waiting time in months, starting off from the onset of symptoms on the far left. And so you can see, firstly, ulcerative colitis is at the top and Crohn's disease is at the bottom. And the most striking thing is that there is a huge difference with Crohn's patients waiting very much longer than ulcerative colitis. Now, this is not surprising because Crohn's can present in a more subtle way. Sometimes it's mistaken for irritable bowel syndrome, for instance. But we can see that both the time from onset of symptoms to first being seen in primary care is over 6 months for most patients. And we can also see that the time from hospital referral to getting a diagnosis is quite long as well, probably 6 or 8 months. And so This is something that we need to do something about, next slide, because it causes significant problems. And some of these are shown here. On the left, you can see some stats about what happens to patients while they're waiting. Increased number of A&E visits, and even some patients being admitted as an emergency. A recent meta-analysis has shown that patients who wait longer before diagnosis are more likely to need surgery. And this paper showed that for ulcerative colitis, patients waiting more than 7 months were twice as likely to have a colectomy compared to those waiting less than that time. And for Crohn's, it was even more striking. Patients waiting longer than 15 months were 4 times more likely to need surgery compared to those waiting less than 15 months. And of course, these delays have impact on education, on working, on quality of life. They also have a significant cost impact for the NHS in terms of emergency admissions, A&E visits, and emergency surgery. And we know that patients who are delayed in starting treatment are more likely to have disease progression. So for Crohn's, that might mean getting stricturing or even having penetrating complications, perforation or fistula formation. We also know now that there is quite good data showing that patients who wait longer to start treatment have a worse response to medical therapy. So all in all, this is a big problem. Next slide. What can we do about this? Well, these are some of our recommendations in the national report. Firstly, we are promoting the National Primary Care Diagnostic Pathway for lower GI symptoms. That has been created in partnership with a number of stakeholders, as shown here in rather small text on the right. This is a generic pathway for all lower GI symptoms and is not disease specific. And it is aimed particularly at primary care, and we need education and training in primary care to roll out this pathway, which I think is practical and extremely useful. We also recommend that fecal calprotectin or FIT test is available across the whole of the UK. There are still pockets where this is not available for GPs in primary care. We think that there should be a nationally agreed waiting time for colonoscopy when IBD is suspected and not just for suspected cancer. And patients with a newly diagnosed IBD should be started onto a treatment plan within 2 weeks of diagnosis. And then lastly, we are recommending that there is a public health campaign to raise awareness of IBD. There was a successful campaign called Cut the Crap a couple of years ago aimed at young adults, which was very successful. We need more advertising campaigns like that to get the public to take their symptoms seriously and do something about it more quickly. Next slide. So moving to a different area now, which is in relation to treatment. More than half of adults reported that they had had 1 or more flares within the last year before completing the survey. And 1 in 3 IBD surveys don't have provisions in place to ensure that advice in the event of a flare is easily accessible. So that's a big problem, and we need to do something about that. Also, 1/3 of patients did not have timely surgery according to their expectations. Next slide. So we are recommending that all patients who request advice or help when they have a flare should have a response by the end of the next working day. We think that we need to define and optimize strategies and policies for patient reviews, in other words, clinic appointments and other contacts. We need to have a clear process so that people who are admitted to hospital have access to an IBD specialist and a colorectal surgeon as needed. And we want there to be nationally agreed waiting times for elective IBD surgery. Next, please. Moving on to another area, personalized care. We know this is particularly important to patients. 1 in 4 services offer a personalized care plan, according to the service surveys, but interestingly, only just under 7% of patients reported actually having a personalised care plan. A third of adults don't feel that their care is well coordinated between GP and hospital. 2/3 didn't feel their GP was knowledgeable about IBD, and a third reported that they were not, only a third reported that they were being asked about their overall state of health rather than just focusing on their gut, diarrhea and abdominal pain, for instance. And only 20% of patients agreed that they were asked about their mental health during consultations. Next, please. So we're recommending that there is integrated mental health support available. This is very sadly lacking across the UK at the moment. Personalised care plan templates should be developed and nationally endorsed to make it easy for this to be available to patients. Structured self-management programs focusing on wellbeing support should be co-produced with service users, in other words, patients. And we need greater use of IT to improve communication and collaboration between primary care and hospitals. Next slide. Workforce remains a significant issue. Half of services do not have enough gastroenterologists or stoma nurses. Only 20% have enough IBD nurse specialists. Only 6% have access to a psychologist, and less than a quarter of services meet the minimum requirements for colorectal surgery, dietetics, or pharmacists. This is pretty terrible, and we really need action there at a service level, at a regional level, and at a national level to improve those stats. Next slide. And then lastly, a slide about pediatrics. We asked patients who were in the adult service and who had transitioned from pediatrics within the last 2 years. We asked them to tell us about their experience. Only 11% had a named coordinator during the transition. Only 12% had an individual transition plan. Only just over a third had been to a joint adult and pediatric clinic. And about 40% were given information about what to expect in the transition process. So we need to do a lot better than that. We need to review the transition arrangements. Again, this should occur both at a local and a national level. Next slide. So in summary, let's have the next bit as well. Yes, thank you. In summary, we've got high quality evidence, both locally and nationally, showing that we do have failings. We need to work to improve things, but we need bold action to redesign services at a local level. We need to utilize patient power. In other words, we need to get our patients involved at a service level. And that's much more important, I think, but complementary to national campaigns. People may say, well, of course, we can't do anything unless we have more staff. And staffing, of course, is a high cost improvement, but there are other improvements that are much lower cost. For instance, improving communication, personalized care, provision of information. And indeed, there are some improvements that would actually save money for the NHS. And I'm thinking in terms of reduction in emergency admissions, A&E admissions, and emergency surgery that can be achieved by having a more timely diagnosis and access to care. And so I think there's a lot we can do. I commend this report to you, and we need to go to work to improve things. Thank you very much.
Thank you so much, Barney. And just to remind everyone, please add any questions into the Q&A, which should be appearing on the bottom of your screen, and then we will look at answering them at the Q&A session towards the end of this. So next on our agenda, we will hear from Caroline, who is living with Crohn's and extraintestinal manifestations of IBD, and is also a peer host with Crohn's and Colitis UK. So we are joined by by Caroline today, but we are going to show a video that she kindly recorded for us.
Hello, thank you for the invitation to share some reflections on the IBD report from a lived experience perspective. My name is Caroline Brocklehurst. I was diagnosed with Crohn's disease in 2009 at the age of 33, and also as a mum of a 5-year-old at the time. Then, following a suspected lengthy delay to diagnosis, 10 years later, in 2019, I was also diagnosed with extra-intestinal manifestations of IBD. They included ankylosing spondylitis, which is also known as axial spondyloarthritis, and that's an incurable inflammatory spinal disease, as well as uveitis, which is an inflammatory eye condition. I'm a peer host volunteer for Crohn's and Colitis UK, and I host IBD meetups across the UK, as well as a peer supporter in a variety of other contexts. I also have a number of patient representative roles in a variety of health policy areas, health research initiatives, and also peer support strategies. It'd be actually impossible to give an in-depth perspective on the vast amount of insight from the report within the next 10 minutes. But I'd like to draw upon a few of the lived experience perspectives within those 4 key theme areas highlighted by the report. And they're around access, communication, personalised care, and also patient experience. Most of us will be sadly all too aware of the damage and impact of delays to accessing a diagnosis. Similar to Kirsty's diagnosis journey case study that's highlighted within the report. However, interestingly, the report also highlights difficulty accessing appropriate treatment and care experienced throughout all stages of IBD patient journeys. These findings are echoed throughout my peer support, where I've listened to heartbreaking stories of both newly diagnosed and those with long-standing disease. And they've been unable to access effective support when encountering disease flares, maybe in changing medications, in developing or managing the correlating conditions of IBD, and much more. Scarlett's case study within the report highlights her poorer support and wait times as an adult of 29 with Crohn's disease than when she was in paediatric care at the start of her journey. Additionally, in my peer support, I listened to experiences of inconsistency and postcode lottery effects, and they're damaging to outcomes, security, and trust. Patients and carers describe the damage and effects of siloed care, including harmful disjoint between GP and hospital access, as well as lack of appropriate access to other specialism support. Nishal, who has lived with ulcerative colitis for 20 years, says in the report, there's also the issue of trying to treat everything that comes with his colitis. He says his consultant knows about gut health, but that he finds himself chasing other doctors who think his consultant should be looking at it more holistically. Also, within Joe's case study, he highlights the commonly experienced lengthening of time to access specialised nursing support, and also lengthening A&E wait times as well. He highlights that patients actually understand that overwhelm facing services. It's not about blame, but it is about recognising the damage and impact and risk of that. The NHS right care scenarios that are highlighted in the report note that optimal journeys are actually often cheaper than suboptimal journeys. But also crucially, they result in vast differences in patient experience and outcomes. And this in turn generates a virtuous compound effect. Effective communication in IBD care is not a nice to have. It is, in fact, a crucial safety feature in patient treatment and care. This isn't unique to this report's findings. Demos, for example, published large-scale research last year in a report interviewing over 2,000 patients called I Love the NHS, But. That report highlighted that poor communication was a leading cause in the majority of harmful experiences in patients' health journeys across the board. Communication includes things like trying to navigate the health system, for example, in dealing with flare-ups, to try to get the right support at the right time. Also, in administrative inadequacies, and them leading to poor communication when there might be problems with care or treatment, or even poor processes to properly communicate and understand medical histories. Almost all IBD services in the report agreed that people with IBD were supported to be actively involved in management decisions of their care. However, only 55% of patients actually agreed. Ticking the box of shared decision-making doesn't actually mean it's effectively implemented or indeed understood. For example, where I can properly understand the need and process of surveillance, my bowel preparation or colonoscopy concordance will then in turn be improved. Or properly understanding the directions, effects, and relevance of treatment options specific to my own disease journey can improve the whole trial and error process to find the optimal treatment that's right for my own specific health and life requirements. Good communication also enables me to trust that I'll be believed if something isn't right in my treatment, rather than floundering alone. Only 41% in the patient survey reported having regular reviews, denoting, of course, a lack of access. But as important is the quality of communication within the reviews and asking the right questions to facilitate effective and efficient care when it's needed. Professor Charlie Lees published his question protocols for reviews at clinic. Inflammatory bowel disease is so much more than intestinal symptoms. Patients might be familiar with being asked questions on areas 2 and 3 of this list, but targeted questions in other areas could truly improve IBD outcomes and do it more quickly, efficiently, and effectively. This leads me on to the concept of personalised care and effectively treating what matters to me. The report denotes that self-reported access to a personalised care plan in adult IBD was actually only 7%. It also notes that only 4 in 10 services report a process in place to ensure that all relevant information is discussed with individuals or indeed recorded at each review. No 2 patient journeys with IBD are ever exactly the same. Lack of personalised care misses opportunities to optimise IBD care to make a difference. This has to be proactive to be effective. For example, patients should be supported to understand how and when to activate patient-initiated follow-up, but also warm hand support with self-management strategies is much more effective and efficient than signposting alone could ever be. I became aware of fatigue management occupational therapy via rheumatology at my local hospital, and I was able to self-refer. Yet, despite consistently clinical fatigue being one of the very top listed concerns and abilities discussed at every one of the peer sessions that I've hosted, I've yet to come across a fellow IBD patient in those sessions who's even been aware of or accessed similar support. The report identifies that only 31% of adults are being asked questions about conditions beyond their gut, despite up to half of patients experiencing extra-intestinal manifestations of their disease, like my own. Also, the report notes only 20% of people with IBD said that they were asked about their mental health in reviews. And that's despite fellow patients consistently highlighting that these other types of disease manifestations have significantly impacted their work, education, relationships, and much more, as well as significantly impacting their IBD outcomes as well. Finally, the report highlights cases of divergence between service-reported delivery and patient-reported experience. Patients and the public are the biggest stakeholders in health. Measuring my outcomes is not just measuring my inflammatory markers against a population average. Like every patient, my diseases don't exist in a vacuum, and all the associated complications, symptoms, and treatments have over the years negatively impacted my health, my career, my finances, my relationships, my mental well-being, and of course also my family. But also vice versa, my life contexts have all impacted my IBD and health and outcomes and experiences too. Gathering, analysing and acting on patient-reported outcomes and patient-reported experiences of treatment and care is a crucial piece in improving outcomes. The report denotes 82% of adult patients not having opportunity to give feedback about their care in the last 12 months. However, we know that often what gets measured gets done. Without the honest data, strategies for movement are blinded. Meaningfully incorporating expertise by experience into authentic co-design is also part of the solution. That involves not only asking for feedback, but genuinely listening and action too. Whilst the report is very saddening in many ways and highlights multiple threats to IBD patient treatment and care, I want to end by noting that it also denotes multiple opportunities as well. There's a story analogy of a person trying to fell a tree, but being thwarted by ineffectiveness by not sharpening the axe in order to do it. This report, for me, highlights the threats, but also gives a foundation to sharpen the tools to improve IBD treatment and care within those four crucial areas of access, communication, personalised care, and patient experience. Thank you.
Thank you so much, Caroline. A reminder of just how important it is to...
Hello. Thank you.
Thank you. To really look at the experiences behind those numbers and what will make the biggest difference to people with inflammatory bowel disease. So thank you so much. We're now going to move on to some best practice case studies. Next slide, please, Nathaniel. So the IBD UK report features data from across the 4 nations, and we have been joined by a number of different healthcare professionals today to share their experiences and examples of best practice from across the UK and areas where there have been particular challenges and where there are opportunities for quality improvement, and how the report can be used to achieve this. So I'm now going to hand over to Professor Alan Lobo, who is going to talk about the Aware IBD project.
Thank you, Fern. I'm delighted to present the work from the Aware IBD project in Sheffield, which was delivered by a wide-ranging collaboration listed here, and with Crohn's and Colitis UK as the lead organisation. Next slide, please. Almost exactly 60 years ago, the writer and broadcaster Alistair Cook suggested that the patient may see a few simple things which you, i.e. those of us in health care, do not see. And this has been a key driver for our Aware IBD project and for the Health Foundation Common Ambition programme of which it was a part, a programme to better understand the role of the public in changing healthcare. Next slide. And at the heart of the project was patient leadership, which we deployed at a number of different levels. We had a patient oversight committee with local and national representation. This graphic is a representation of their role, their representation of the role that they brought, bringing lived experience to discussion about service change. The service changes were discussed and planned using a microsystem approach, which is a formal quality improvement methodology. And for the first time, this was led, coached by a service user, Sam McCormick, and I'm very grateful for the time and effort that she put into that. And the metrics, the materials, the interventions were all co-designed in planned events with people living with colitis and Crohn's disease, including a novel measure of patient experience, a toolkit to support communication with the healthcare team, and a personalised care plan. Next slide. We asked people what matters to them, and very similarly to what's been identified in the report, they prioritised personalised care, access to the service, and communication. And we also held a number of events to understand the barriers faced by those from underserved populations based on ethnicity and deprivation. And the issues that they raised, perhaps unsurprisingly, were all underpinned by trust in the service, trust in institutions, trust in professions, and some of those are listed on this slide. Next slide, please. We developed a number of interventions, some of which I've mentioned, but in this very short presentation, I want to just highlight the role of the personalised care plan, which have already come up in the presentations. And you've seen that they are a key recommendation as a national standard of care. Our personalised care plan in Sheffield was co-designed with people from the service. It covers inflammatory bowel disease history, contact details for the team, including during a flare, an account of how things have been going, a space for discussing dietary and lifestyle issues, and then a plan for next steps. But it's this box here in the middle of the right-hand side of the slide, what matters to me, that I found particularly helpful in embedding the discussion of wider concerns that people raise. And examples of the sort of thing that came up in discussion was the everyday impact of fatigue, of anxiety and depression, and the impact of perianal disease. And as well as bringing these items out for discussion, people appreciated that permission to discuss these items in a consultation that might otherwise not have accommodated them. Next slide. We ran this pilot in 67 patients in our clinic. There was a small but statistically significant improvement in the patient experience, particularly for the what matters for me part of our experience measure. But it is perhaps best illustrated by some of the qualitative feedback that we had from the structured interviews, the ability to frame difficult conversations, the ability to put down things that were important that you might not otherwise have raised, being able to facilitate or encourage holistic conversations, and to give people confidence to in what might otherwise have been a daunting consultation with the healthcare team. Next slide. And as a result of this work, I'm aware we've not presented all of this, these are some of the recommendations that we have made in our report to the Health Foundation. That service changes in inflammatory bowel disease should be led by patient priorities and co-designed by people with lived experience, and leadership should be part of that process. listening to underserved population should be undertaken in a meaningful way that allows us to address their barriers to engagement. And services should aim to understand what matters to people with inflammatory bowel disease, prioritising, again, as we've heard, personalised care, good communication, and access to the service. And the measure that we've developed does, I think, demonstrate that patient experience can be measured and embedded in inflammatory bowel disease services. Next slide. And this is a recent letter from one of our patients. He wrote that clinical aspects of the care he'd experienced had been good, but he went on to write, it's the very positive contribution to the quality of my life, which is not always measured as part of a medical process, that I want to focus on. Our experience in Sheffield therefore reflects the wider feedback that you've heard from the UK and from the report, and describes an approach that can be used to engage the patient voice, which is such a key part of the recommendations from this report. Thank you.
Thank you so much. I'm going to hand over to Dr. Claire Tibbetts, who is the IBD Clinical Lead for Wales.
Thank you. Good evening, everyone. So I've been asked to talk about psychological services and how they're embedded in IBD services, or the lack thereof, more importantly. Next slide. So we know that there are 59 standards, and psychology services are mentioned in at least 6 of them, but it's one of the most poorly measured outcomes in IBD treatment and one of the most poorly delivered. And we know it's throughout the pathway. Getting a new diagnosis of IBD can be very shocking, particularly for young people. It's a disease of young adults. And then along the pathway, these are people who are trying to complete their education. They're trying to maybe have babies, have children. They've got to work with this condition. So pain and fatigue are a very common complaint, but one of the most poorly managed symptoms of IBD all along. And we don't really measure it very well. In a 10-minute consultation, we might vaguely ask, how are you doing? But we don't generally do questionnaires and scores and identify this and measure the improvements. Next slide. So we've just done a baseline collection of data in Wales across the 7 health boards, and there is no adult psychological service in Wales. Less than a quarter of people actually asked about it in their outpatients. And there is no established service, as we said, in the adult service, but there is a very fledgling service in the paediatric hospital in Cardiff, which has 1 psychologist. They've started a brilliant service, but it rapidly outgrew the demand, and they've already had to stop accepting referrals because the number of patients wanting to speak to them was so huge. Very few services actually have specialist psychology input, particularly as we say, surgery is a major issue for young people having to undergo stoma surgery. Most of the stoma nurses are cancer nurses, and they don't have the specialist training for IBD patients. And there's no plan in Wales at the moment of what to do. We are taking this on as the NHS Exec Clinical IBD Implementation Network, and we're looking at what the service should look like. Next slide. So what does the psychological need of our IBD patients look like? When we say psychology and mental health, we often think of depression and counselling and outpatient appointments, and that's not just it. There are patients on the waiting list, they're becoming deconditioned, and we know when patients are not well, they usually go one of 2 ways. They either disengage with the service or they have increased hospital contacts. Their physical health gets worse, maybe because of non-compliance, and the demand on the service is increased as well. And the resources needed to manage patients with poor mental health and IBD is significantly greater than patients who are aided to help cope with the disease and have their psychological symptoms treated as well. Next slide. So what do we need to do? There are many similarities across all chronic illnesses, and we've got to remember it's not just the patient that's affected, it's their family, particularly as we say this is disease of young people and there's a significant pediatric population as well. You've got teenagers who are addressing their sexuality, as we said, might still be in school, university, starting out with working. So it impacts not just the patient, but all these aspects of their life and their carers as well. There's a risk of eating disorders particularly in our young patients. So if you experience pain with eating, you may develop behaviors and patterns that can lead into greater problems later on down the road. And there are patients, as we say, teenagers don't want to be well. The need to accept surgery, the need to accept injections, blood tests, all of these things are very distressing for patients. And you may find their compliance is worse and their actual physical health then declines, as well as their mental health. Next slide. So what do we need to do? As we said, many people, when you think of psychology services, you think outpatients and counselling, but there are many ways that a psychology service can help us. And I've had the privilege of speaking with some psychologists who manage other long-term conditions such as lymphedema, and this is some of the information that they've given us that works in their conditions. There is, of course, the direct patient contact. You may have patients, as we said, who are needle phobic. I actually had one patient who we put through a hypnotherapy course who went from not being able to have their blood tests, not accepting of any treatment, who is now in total remission and self-administrating their ustekinumab without needing to come into the hospital and managing well at home. You have particularly young people who are in denial about their condition and they might disengage. We need parents. Obviously, it's very distressing if your child is diagnosed with a lifelong condition and you have kids who have medical trauma from investigations, and there's a lot of anxiety around ill health. And of course, your staff might need support as well. We all know the NHS is under demand. None of the IBD services are resourced adequately. So there's a lot of pressure. And it's not just one-on-one clinic appointments. There are now online services, counselling, group counselling, play therapy for younger people. So it's not just that one-on-one outpatient appointment. And then there's the indirect support that they can offer to people as well. Going into schools, raising awareness, helping school nurses, training them how to manage their condition at a young age. Being an important part of the MTT, advising how patients maybe who have disengaged, who are not accepting of surgery, who are not accepting of treatment, advising the staff how to manage these patients, how to increase their compliance, how to get them to engage. So the psychologist actually coming to the joint clinics is very helpful, meeting them in the clinical setting to ask about their mental health, to assess how they're doing and help them with their treatment. And then there's also training. They're really important in educating clinicians who are looking after these patients. We're all very good at asking out how bowels are. We're not so good at assessing the mental health and signposting people to the resources that they need. And it's not just one-on-one, as we say, there's online resources, there's support groups, there's information that can be done outside of a hospital setting. Next slide. So what does this look like? At least in Wales, we're looking at a plan for the entire nation. You need leadership to look at the national pathways and then the smaller regions within the health boards. Then you need the clinical staff to actually provide the clinical counselling, the psychology in the different ways that we've just mentioned. And do we need to look at things like helplines for psychological support, just the same way as we have an IBD helpline for patients with their physical complaints and their flares? So in summary, we know that this report and all of the surveys to date show that this is one of the most under-resourced and underappreciated services and part of the treatment for IBD. It's not measured well, it's not delivered well, and poor mental health can lead to poor physical health and an increased use of hospital resources. So we need to raise this as much as we can with the government. We need to come out with a national plan. We need to raise this profile, and this needs to be alongside all the physical and the clinical changes that are happening. This needs to be a priority, not just for Wales, but the whole of the UK. Thank you.
Thank you so much, Claire. Next, we're going to hand over to Dr. Andrew Murdoch, who is a consultant gastroenterologist at Southern Health and Social Care Trust.
Good evening from Northern Ireland. Thank you for the invitation to talk about some of the issues affecting the Northern Ireland region. Next slide, please. I'm just going to, obviously, as people have said, there's quite a number of standards. I'm just going to highlight 3 areas which I think are of particular need within our region. Next slide, please. Just like the rest of the UK, unfortunately, there isn't a single service in Northern Ireland which meets the current IBD standards. In certain trusts, there are significant deficits in consultant numbers. All trusts do not fulfill the MDT requirements as laid out by the standards. As people have already touched upon, transition clinics, unfortunately, have begun to become almost on an ad hoc basis, which is not what we want for people at a particularly vulnerable stage of their lives. Because of the pressures on the system, quality improvement has really taken a back seat as we try and firefight more and more. Patient engagement was really hit by COVID and hasn't recovered. It would be great to see the revival of patient panels locally, as I think these give a more continuous feedback to a service rather than simply the episodic surveys, which are helpful, but I'll say episodic in nature. Psychological support, Claire has put it better than I ever could regarding the needs. There isn't a single service in Northern Ireland that has this. CCUK and myself have written to our mental health champion regarding this, highlighting there is a need for support at all levels, from simple communication skills to people who do require more intensive therapies. But unfortunately, this is at present falling on deaf ears. Next slide, please. Pre-diagnosis, as Barney has already highlighted, there is the lower GI pathway, and I think this is a real opportunity to standardise referral practices in Northern Ireland. We are, through the auspices of the Primary Care Elective Group, looking to bring this in. As I say, I think it will enable people to be signposted to the correct service in a more timely fashion. But unfortunately, talking about times, I'm just going to have a couple of slides here looking at time for clinic appointments and time for diagnostics. I'll go to the next slide, please. This gives you an overview of the average waiting times throughout the 5 trusts in Northern Ireland. Really, IBD patients do tend to end up in the urgent slot. And as you can see, ranging from 30 weeks to 93 weeks. Putting aside the complete unacceptability of 30 weeks as the best waiting time, the fact that there's a 3-fold difference between 2 trusts in such a small region is completely unacceptable. Next slide, please. The pressures don't just affect people who are waiting for a diagnosis, they also affect our existing patients. This is data from my own trust, and I think it shows a number of things. First of all, it shows the immense workload that our IBD nurse colleagues are dealing with. Phenomenal numbers of calls, but when a system is put under more pressure, the calls really ratchet up. Comparative time periods with a 1,300 difference between the 2 periods, which is really showing that the service is becoming reactive rather than proactive, which is all the speakers before have said this is not what we want from a modern IBD service. Next slide, please. Colonoscopy waiting times is a barometer for all diagnostics. As you can see here, again, there's huge variations. 128 weeks for an urgent colonoscopy. That is not an urgent colonoscopy in anyone's definition. And as one of the speakers already touched upon about surveillance colonoscopies, a lot of these do tend to end up in the routine section. So to have a waiting time from 48 weeks to 220, depending on where you're living in Northern Ireland, is wrong, and it should not be allowed. Next slide, please. We do have some positives, some chinks of light. We developed an electronic flare card to enable and to promote self-management. This was developed by our IBD nurse colleagues and some interested IBD clinicians. It was initially as a paper card, but the Department of Health saw it and agreed that this was very useful, and we've now got it as an electronic card, and that is rolled out throughout all the services in Northern Ireland. We also do have fecal calprotectin available in primary care throughout all regions in Northern Ireland, which is a success. However, I do think that integrating the referral pathway would really make sure that we're getting as much bang for our buck with this really useful test. Again, said signposting people at the earliest opportunity to the correct service, so they're not joining one waiting list to be told, oh no, you need to see somebody else, and then joining an equally long waiting list. Next slide, please. So in summary, unfortunately, there is a postcode lottery regarding waiting times for clinics and for endoscopy. There is the regional endoscopy group, which is beginning to look at these differences in waiting times. But I say we're in the mouth of Christmas, so if Santa can bring me something, if he could bring me the ear of the Health Minister of Northern Ireland, because I think we need to have a serious talk about IBD care in Northern Ireland. Thank you.
So much. We have one more best practice example. So I will now hand over to Dr. Ian Arnott, who is a consultant gastroenterologist at the Western General Hospital at NHS Lothian.
Thank you very much for the invitation. I was very honoured to accept. Next slide. I chair the Scottish IBD group. So the Scottish IBD group is part of the Centre for Sustainable Delivery, and the Centre for Sustainable Delivery is a service in Scotland that supports quality improvement across every speciality. And the IBD part is one very small group. Have a very functional, cohesive group that has representatives from every health board in Scotland, and we are truly multidisciplinary. So we have nurses, dietitians, pharmacists, medics, psychologists, and hospital management that all try to come to our 3 or 4 meetings a year to support IBD quality improvement in Scotland. And what we've tried to do over the last few years is to take 2 or 3 work streams a year. And the report that we see today from IBD UK is really vital data in terms of the topic selection, in terms of driving what's important, particularly to those people with IBD, in terms of how we improve our service. So for example, in 2022, we tried to empower sites to make a difference to their service with no additional resource. And I'll come on to 1 or 2 things that we've done through that process. We also did a staff mapping exercise, mapping IBD standards to service provision in Scotland. And again, I'll show you about that before. We tried to develop an electronic care plan. I was very interested to hear Alan's data about the value of that. And this year, we have developed an IBD, a Scottish IBD referral pathway to try and prevent some of the delays in diagnosis that we've heard about earlier this evening. In 2025, we're hoping to roll out a national enteral feeding pathway, a good program of a patient-initiated follow-up, and we're talking about biologic sequencing. We also do other work that's not been driven specifically by the Centre for Sustainable Delivery, such as supporting the lower GI pathway that Andrew was mentioning earlier. Next slide, please. And this is a graphical representation about how the 11 health boards in Scotland match up to the standards. And you don't need me to tell you that it's patchy. And I think it's really interesting that particularly for more services in Scotland is pretty pitiful. And we spent quite a lot of time and a bit of money last year developing a psychology business case that was just totally knocked back. So these are some of the challenges. So these are some of the real challenges in improving our service. And as you can see, pharmacists and our pharmacists are just a vital part of our service, and our dietetic colleagues as well, who you can't do it without, are provided in a very patchy manner across the country. Next slide, please. And so, what have we done? And this is just one of the examples of some of the work we've done in Lothian about health miles. So we've, through COVID and beyond that, we brought out virtual appointments, and Lothian spans a pretty big geographical area, but we've saved a huge number of health miles and a huge amount of traveling, which supports, we hope, people getting to work, spending time with their families, and not spending hours in the car park or the queue to enter the hospital car park. Next slide, please. And really to sort of bring it down to a site-specific level, and this is what we hope that some of the work from the Centres for Sustainable Delivery has done. And certainly, if you can see in our positive changes through the that site-specific QI that we led before, we instituted a pharmacy-led post-induction clinic for all of our people who were going on to advanced therapies. We've developed biologic algorithms that hopefully span out through the southeast of Scotland. We've made changes to our helplines and to the work that the vital work that our IBD nurses do. And I think that one of the things that I really wanted to emphasize is the sort of value of a coherent, multidisciplinary QI team within a country and within a hospital, because they all feed into each other, they support each other's work, and I think we can make really significant changes with very little money. The top the top left panel there is a reflection of some of the work that we did again post-COVID about a flare clinic, and this shows that the quality of service given to patients has improved. Managing costs is obviously a vital issue, and I think all of the work that we've done, and I echo completely the statement before about good quality care being cheaper than poor quality care. So virtual clinics, pharmacy input, newer options for cost avoidance, and horizon scanning have all been, again, vital things that have come out of this process to support quality improvement in Scotland. I hope this has been just a little sample of what can be achieved with very little resource, and I think the IBD UK report is the sort of vital chunk in driving that. Thank you.
Thank you so much, and thank you to all of our speakers. We have now some time for questions for the panelists. So again, huge thank you to everyone who has submitted your questions through the Q&A. Just to let you know that as we only have a short amount of time today, we may not be able to get through all of them during the session, but we will review them afterwards. And also thank you so much for all the comments that you've been sharing throughout the sessions as well. I think it raises some of the huge challenges, both from a clinical and from a patient perspective, and we will also make sure that all of those are shared as well as the questions. So one question was around someone raised that there's a block on creating new positions in their service, and that they're concerned about long delays that patients face. So how can we ensure that these recommendations are influenced so services can better deliver for patients. And a question linked to that is really around how we, IBD nurses and multidisciplinary teams, can petition trusts to give funding and time to develop simple options whilst staffing remains so dire. And our panel would like to take that. We could.
Do you want me to have a go at that, Fern?
Yes, go for it. Yes. The first part of the question around how we can ensure that recommendations are influenced so services can best deliver for patients.
So I think it's a really good question, and it's dead difficult. And I think everybody around the country is facing financial troubles. And I think not now, but if I go back to when we got some funding for IBD nurses, I often say to people, well, it only took me 10 years. So I think persistence is good. But what I think from a practical point of view, what was really important was that cohesive body of opinion that supported the intervention, whatever that be. So for example, at the Western, we have a very cohesive QI group. And so that has a much stronger voice than a single person. So get together with your colleagues. And then when we did get funding for some IBD nurses a few years ago, what was really important was the patient voice, which was, and I can't underestimate how important that was, but also Crohn's and Colitis UK were a vital voice. And then in Scotland, the CPG, the Clinical Priorities Group. So as an individual clinician or group of clinicians, I think it's really difficult to just stand up and get your head above the parapet and get what you want. So I would say it's a cohesive group approach to a problem and to persist at it, because it's not easy.
Thank you so much. And just opening up to other panelists for the second part of the question, and how can teams petition trusts to give funding and time to develop simple options like electronic personalised care plans and other measures. So Alan, I don't know if you want to come in around that.
I mean, as is implied on that question, it is really difficult because priorities are not necessarily with a long-term illness and might be focused, particularly in COVID recovery, on other aspects or maybe higher profile aspects of care. But just echoing perhaps what Ian said about cohesion and persistence, but I think that coherence and persistence, and maybe that needs to be at different levels. It certainly needs to be at a local level, but I think that national initiatives are also helpful. So a report like this actually is influential and is important because it gives something that trusts can point to, or that clinicians can point to and say that this is a national standard of care. We should be meeting that. And I think there do seem to be signs from the new NHS initiatives that patient voice and moving things to, or looking at other aspects of care other than just numbers are important. So I think that lobbying and the discussion at a national level is really important. And then at a local level, as I said, talking about the report, getting it right first time. Initiative has progressed a bit, and I think the patient voice is an important part of that too. And trusts have recently been issued with guidance about making sure that they have patient voice. So it is trying to use all those fragments, both on a national and a local level, and then trying to understand what matters to your trust in terms of reducing admissions and reducing outpatient attendances and the benefits that come from an empowered patient population. So I think it's cohesion and then also looking at the fragments of the picture to try and build that up.
Thank you so much. A question, Andrew, Claire, if you'd like to come in. One of our attendees has said, I feel like I let my patients down every day. I know I give them the high quality care when I do speak with them, but I get pulled in so many directions. It's hard to remember to chase everything for them. And my week is filled with firefighting on the advice line and clinics. I find it so hard to look into service development that would actually improve patients' lives. Why is the caseload so much higher post-COVID? And I guess the question there is how can teams focus on improvement when they face all these challenges every day?
Yeah, this is something we're looking at in Wales. We've just done a baseline data collection to see where people are in relation to the standards. And we've come up with action plans for the health boards of things both to be done locally, but things that we're doing at a national level. So in Wales, we're lucky to have the NHS Welsh Executive IBD Implementation Network from April. And we're looking at things like standardizing the approach, writing the protocols for the health boards. So things like standardizing pre-immunization screening, vaccinations, because we know clinicians don't have the time. And during COVID, patients weren't being seen. And now all of a sudden, we're all doing our endoscopy recovery plans. We're all doing weekend working, insourcing. And the number of patients that have been diagnosed has gone through the roofs post-COVID. And we don't have the same resources that we did before. There's a lot of focus on the front door. We know there's a 50% vacancy of gastroenterologists across the country. So we don't have the staffing to manage with these patients, but we are looking to do as much as we can on a national level and share that through our website and share that for the trust so the individual clinicians don't have to do it. And one way to address the funding situation, we're also looking at invest to save schemes in Wales. We all know biosimilars are out there, new medications coming all the time. So we're developing a preferred prescribing pathway and demonstrating the savings that can be made from swapping your medication and agreeing a proportion to be reinvested back into the service. So we're trying to get that implemented or at least supported at a national level to make things easier for the trust in Wales. So if anybody's interested in helping with these things or wants any more information, more than happy to share the work that we're doing.
Thank you. We have a short amount of time left. Is there anything that you'd like to add?
I'm just going to look at the question slightly differently. What I'm taking from that question is the issue regarding moral injury, the anguish that we all go through every day, knowing that we're working in an imperfect system and knowing that we're just not hitting the targets that we want for our patients. So my kind of view on this question would be, for all healthcare professionals on the line, look after each other, look after your team, take time, sit down, have a coffee, just say look after your team, because if you don't look after the team, nothing is going to work. So I appreciate that's coming from a physician point of view, but I'll say that's how I would look on it.
Thanks so much. So we're coming to the end of our time. As I said, we will look through all the comments and the questions after this. There will be an email address if anyone does want any more details or to follow up. And thank you so much to all of our speakers and to Caroline for sharing her experience and what makes a difference for patients. I'm now going to hand back to Jackie to close the session.
Thank you, Fern. So what an interesting hour and a quarter we've had. Great work for this very important report. Just summing up very, very briefly some of the commentary, the really interesting commentary. Clearly, the issue with mental health, lack of access to psychological help, lack of communication between departments and agencies, lack of staffing and funding. We've touched on waiting times, patients being failed by lengthy processes. Discrimination at work came up a lot in the chat, and this difficulty in focusing on prevention with a sort of emphasis in the NHS of always treating emergencies, and the lack of financial support for those living with Crohn's and colitis. So I just wanted to pick up a little bit of the commentary that didn't come into the questions necessarily, to thank everyone again, to thank particularly the Alliance, IBD UK, and all the hard work from everyone involved for a very important report. Have a good evening, everyone.
Everyone.